Okay, good afternoon, everyone. Like you said, my name is Effie. I sit on the public health team at Camden and Islington, and myself and some of my colleagues have been working on an evaluation of health and wellbeing referral hubs across both boroughs. And the reason for that is because we are seeing this emergence of social prescribing schemes, which essentially do refer people to community-centered services, and that's kind of more targeting the non-medical reasons for poor physical and mental health. So the National Institute for Health and Care Excellence guidelines recommend these single point of contact referral services be made available by local health and social care commissioners, and the idea being that multiple needs can be addressed in one contact. So because there was limited, although growing, evidence about the success of these referral hubs, we felt an evaluation of this sort was timely. Now, the local picture in Camden and Islington, we have two different referral hubs for each borough. In Camden, we have WISH Plus, it stands for Warmth, Income, Safety, Health Plus Service. And then in Islington, we have SHINE Service, that's Seasonal Health Interventions Network. So what we wanted to do with this evaluation was clarify the process by which referral hubs are delivered, identify which populations referral hubs reach, and understand the perceptions of referral hub staff and service users. Though for our purposes today, I'm just going to be touching on the service user element, but we are going to be publishing the report very shortly, so you're more than welcome to take a look if you're interested. Just to give you a little bit of an idea as to the delivery pathway, essentially just a very high-level scope. We have partner services that broadly fall into health, housing, social care, and carers. They make a referral through an online portal or directly by phone on behalf of residents, or residents can call in themselves to self-refer. There they speak with an advisor who then can assess them either directly for onward services or could do so via someone going to their home, have an energy assessment, and then potentially also still refer to those onward services. So what we did was kind of undertake this mixed methods design, whereby we were going to look at service records from the previous 3 years, so from 2015 to 2018. The quantitative data was analyzed using descriptive statistics, but then we also wanted to conduct surveys and interviews. So we sent a postal survey to 400 residents, 200 in Camden, 200 in Islington, from May, and kind of allowed for them to be returned up until August. And with those interviews, participants were able to indicate if they were interested in being contacted for a potential follow-up interview. So we had a pretty low response rate, 34 residents returned postal surveys, and we were able to conduct interviews with 9 of them that lasted approximately 30 to 60 minutes. But we were able to reach saturation with themes with those 9. Now the framework we used with respect to service users, it was a bit different for staff, but with service users, we chose to adopt a capability, opportunity, motivation model of behavior, which suggests that the interaction between capability, in other words, an individual's psychological and physical ability to engage in an activity, opportunity, so factors making engagement in the activity possible, and motivation, which is the individual processes driving the behavior, so that could be an emotional response or kind of a decision-making process. All of those go together and cause a range of health behaviors, including potential service access. So that framework was used both to guide our interview schedule, but also for subsequent coding of the interview transcripts. So what we did find in kind of reviewing the service data was that both referral service hubs had similar demographic and referral patterns. There are about 6,500 referrals made to SHINE, 5,500 made to WISH Plus over the 3-year period. And on average, about those services were referring to about 2 onward services. So 12,000 referrals by SHINE to onward services and 10,500 made by WISH. For both Both of them received the majority of their referrals from council staff. And with Shine, we saw they were most commonly referring for financial support and keeping the house warm, and Wish similarly also with keeping the house warm and with home safety. And the majority of referrals with both services were for residents living in council-owned properties and in more deprived areas. So kind of looking at what our interviews revealed and survey data revealed was that participants generally did have a good idea about what was required, what was required for them to actually engage with the support available. Even those participants that felt they did hold a lot of knowledge already did see it as a means of kind of filling the gaps. With respect to opportunity, it was the idea that it being easy to access when staff initiated a visit or when staff instigated the referral to the onward service rather than leaving it up to the resident to do so on their own accord. That had a big shift in how residents felt their opportunities were improved, and conversely, when it was difficult to speak with someone at the services, that limited their ability to do so. And lastly, motivation. We found that residents were prompted by the situation that they found themselves in. So if they felt their situation was becoming unmanageable, they were more likely to feel open to engaging with the services, rather than if they had a number of other things going on, they felt perhaps it wasn't quite a priority. So if it was good timing and they were energized and ready to take up the service, great. But if they had a lot of things going on, they just didn't feel ready at that point. Now, there were some limitations with our work. So for starters, a retrospective review of the existing data. We were limited by the data already existing. And what we found was that there was a lot of demographic data missing. You notice I didn't mention anything about gender or ethnicity. That's because there was such a substantial portion missing. It wouldn't be viable to make any inferences from that. And also, of course, the survey and interview data was captured at one point in time about their perceptions, but of course we know perceptions can change over time. So perhaps future research could conduct something a little more longitudinally to see how those perceptions might change over time. And of course, the small sample of survey data due to low response rate was a bit of a limitation as well. But despite all of that, we were able to pull out some key learnings. So increasing reach among the target vulnerable population. So for the wider community of local residents, we felt they could benefit from knowing specific information about the referral hubs and who they can support and when to contact them. Also, feedback about onward services, onward service support. So engaging with routine follow-ups with residents could ensure that staff at referral hubs have the feedback about whether residents received the support they needed at that onward service, and create the potential for building in capacity for staff to do so should be something that's considered. Promotion of the services with healthcare professionals. Further efforts are required in promoting these services in those kind of healthcare professional settings, and then being able to ultimately have another avenue to refer residents into these referral hubs. And lastly, providing a variety of support efficiently. So especially when residents present multiple complex needs, staff should elicit and prioritize residents' main concerns and build in the capacity to follow them up. So a regular and mutual review of eligibility criteria among services with whom referral hubs hold agreements with would also be highly recommended. Thank you.
Much. Yet again, any brief questions of clarification? No? Okay. Well, there's one there. Oh, sorry, I didn't see you. I'm sorry if I didn't catch this at the start. We have something similar in our borough, and I just wondered if, for comparison's sake, if you could explain whether, or clarify whether your service has a has entry criteria? I know you said people can refer themselves to it, but is there just eligibility criteria?
I believe there is, and they would differ slightly. We analyze both services, the data together, although each service is distinct. But typically they are to support more vulnerable residents in the communities. So that would be more up to the advisor to make that assessment and be able to refer to onward services or not. But that would happen at the point of contact with the service.
Thank you very much. Great talk. And we're going to move on to another talk about the Borough of Camden and Islington from Alexandra Smith, who is a public health registrar from Camden and Islington Public Health. And she's going to be talking about food poverty in Camden and Islington.